Introduce. Yeah. So, good evening, dear friends. So, as you know, today is our 40th episode of Apollo Mumbai Critical Care Learning Network, and today's topic is community acquired pneumonia from the intensivist perspective. So, basically, this topic is very one of the you can say the important topic for almost all the intensivists, because as we know, like the last wave of epidemics of COVID. So everybody had suffered one or more similar incidences in their lifetime, and the intensivists should know when the patient is become critical and he comes to the ICU, and how to manage it, and what are the different other methods of treating the community acquired pneumonia. So it is basically a burning topic nowadays, specifically when now the influenza and the H1N1 is also spreading like anything. So probably the focus is on severely ill, critically patients who are coming to the ICU. And today we have our esteemed speaker, Dr. Barnali Datta from Medanta Hospital, Gurgaon. She is instrumental in describing this topic in her own way. And hopefully this will throw some light on the current management of patients with community acquired pneumonia. So Madam is a chest physician, consultant chest specialist, and practicing, you can say, the chest physician come intensivist in the Medanta Hospital, Gurgaon. And with this, my co-colleague, Dr. Akhilesh is there. And I welcome you all. Myself, Dr. Gunadhar from Apollo Hospital, Navi Mumbai, Senior Consultant Critical Care Medicine Specialist. So, without much delay, let's start the topic, and hope this topic will be very much interesting, and it will be helpful for our DNB fellows, practicing intensivists, and other who are giving the exams in the coming days. So I request all of you to put your questions in the chat box. At the end of the talk, Madam will take and we'll both discuss one by one your questions. Thank you. So over to you, Madam.
Thank you, Dr. Gunadhar. It's an honor to be here. And before I start the talk, I'll just one submission that I probably will be coming more from a pulmonary perspective. So apologies in advance for that. I think community acquired pneumonia, while of course the severe cases will always be directed to the intensive care under the care of the intensivist, but there is many steps before that. So I'll go over everything. If there are any gaps in the understanding, then of course Dr. Gunadhar and Dr. Akhilesh are there to do that. So I'll begin with screen sharing. So community acquired pneumonia. So these are the guidelines that I have derived from. The latest guidelines that we have are actually from the ATS, American Thoracic Society, and the Infectious Disease Society of America, which is from 2019. They have further guidances on influenza, COVID. BTS, the British Thoracic Society, is a bit old, 2009. Indian guidelines are also there from 2016. I have taken some from the anesthesia perspective, but more I again reiterate is from the pulmonary perspective, and then up to date is a source that we all go to, which has of course everything under one heading. So the scope of talk: what is community acquired pneumonia? What is the clinical presentation? Determining severity. This becomes very important, diagnosing it and determining severity, because based on that, we then decide, do we admit or not? And after admission, does the patient need ICU or not? So the sick cohort who land up in ICU are the ones that you will be dealing with. Whereas in the pulmonary perspective, we often deal with them in the outpatient setting, or sometimes even in the wards, of course. The treatment and duration, and a few special cases, follow-up and things like that. What antibiotics, about the bacteria in more detail. So what is community acquired pneumonia? It refers to acute infection of the lung parenchyma, which is acquired in the community, which is outside the hospital. This is different to nosocomial pneumonia, which we often recognize, and perhaps what you see more often in the ICU setting, which includes both hospital-acquired and ventilator-acquired pneumonia. And this is within a 48 hours of either admission, more than 48 hours of intubation. So this is different to community-acquired pneumonia, where the infection has been picked up in the community. Healthcare associated pneumonia has now, the term has been made redundant, and I'll just make one point about it. It is now abandoned, but it was taken up as an entity wherein it's an infection which is picked up in the community, but with drug-resistant bugs. And this is because of either recent hospitalization or because of staying in a nursing home long-term facility because of dialysis. And so continued exposure to healthcare setup, which led to resistant bugs. However, it was found after this entity that there was a lot of, needless increase in the use of drugs. So that's why it has been abandoned. Now, as Dr. Gunadhar pointed out, community-acquired pneumonia, it is a very important topic. Why so? Because it is an infection that ranges from just a simple cough and cold in a healthy, immunocompetent young man to very, very critical illness where patients are then in ICU and, often life-threatening. So that is why that whole spectrum, we need to understand what causes it. We need to identify the sick patients quickly and then institute the correct antibiotics quickly without overusing, underusing, abusing, misusing, etc. Which, as you know, antibiotic, that is a very key thing for us because we've lost out on key antibiotics because of improper use. And I think antibiotic stewardship is now a very, is something that is in every hospital and every ICU. Now, clinical presentation that we would see of any patient, cough and sputum production will be there, in 90%. More important than that is fever. Now, fever is the key thing when we suspect pneumonia. Like many patients can come with cough and, it can be airway disease, it can be bronchitis, it can be so many other things. But when it is associated with fever, then we think of an infective cause. Chills may be there depending on the level of illness. Now, again, as it's mentioned here, fever is not so common in older people. And older people, immunocompromised, etc. So again, we need to have that understanding that not every patient will have fever, but by and large, 90% will have fever. Tachypnea, sometimes pleuritic chest pain, if the pneumonia is on an edge and there's pleural inflammation and pleurisy, then of course there can be a degree of pleuritic chest pain. Auscultation will have lots of chest crackles, and then we can have, sometimes you can get a bronchial breath sound because of the consolidated lung parenchyma in which there's patent airway. And so the bronchial breath sound is transmitted. The first thing to point out is that you need an X-ray to diagnose pneumonia. If your X-ray doesn't show pneumonia, doesn't show consolidation, then you cannot say this is pneumonia. Then it could be bronchitis, it could be LRTI, URTI, or any number of those kind of basket diagnosis. But pneumonia requires you to have consolidation, and that is the typical understanding of this. What are the risk factors for developing community-acquired pneumonia? Why is it that not everyone will develop it? Why are some people more prone to it? And these are the risk factors which apply across the board for any acute infection. So this is pneumonia, but it could be the same for respiratory illnesses, for any other illnesses. Age is a very key factor. Older age, chronic comorbidities, so anything, chronic kidney disease, heart disease, liver disease, anything that you're living with will make you more susceptible. Viral respiratory tract infection. Now, this is a very important thing because, as we know, the viral infection in the lungs can, severe infections can even present as pneumonia. But additionally, they can pull down your immunity so that you get secondary superadded bacterial infections. Smoking and alcohol overuse, other lifestyle factors, which is socioeconomic more than anything else, and then a combination of any of these risk factors. These are important for you to know in your history taking, because you are then gearing up to know what you're dealing with. Could this patient become severe, even though he isn't right now? What is the prognostic factors for these patients? So risk factors are important for us to acknowledge. Then we come to this very important thing of who to admit. Now, this is not relevant to the intensivist so much as the physician, the pulmonologist, or the internal medicine physician who's sitting in the OPD. Clinical severity, which we will discuss in detail, is one of the key things that we need to look at. But other than clinical severity, you have to take a holistic view of a patient and decide on admission. Like, for example, if there's a medical psychosocial contraindication to outpatient therapy. And this can, again, be numerous things. Inability to maintain oral intake. So, then we may need to give intravenous and things like that. History of substance abuse, cognitive impairment, severe comorbid illnesses, and impaired functional status. So again, it boils down to the same thing, that you have to see the patient in totality. You're not dealing with one single thing. Now coming to this clinical severity. Now there are two key severity scores, and I'm sure you're familiar with these, and I will just go over them in a little bit of detail. So pneumonia severity index. This has multiple variables. So these are the key variables which has several parts to it. So patient characteristic, coexisting illness, which we already discussed. These risk factors are very key. Any chronic disease, as we can see here. Physical examination findings become very important. So respiratory rate, blood pressure, temp fever, heart rate, if you're confused, altered status of the mental status, and then lab findings. So clearly we are looking at, we have the blood reports, we have the X-ray, and then we are taking a call whether we need to admit the patient or not. Lab findings, pH, sodium, urea, hematocrit, blood glucose, and the actual oxygen level. And radiological finding, pleural effusion. So this is what PSI uses, and with all of these are given scores from 10 to 30, and this is added up, and then it is broken into classes, divided into classes. So class 1 and 2 is anything under 70, and this is low risk and can undergo outpatient treatment. 3 becomes intermediate, and you may want to admit, and 4 and 5 you admit, and you also consider whether he needs more high-end treatment, preferably ICU. They say preferably ICU, so bear that in mind. The second one is CURB 65. Now, CURB 65, of course, is something that is used because it is very easy to use. You and I can be sitting can be in emergency or in OPD and just look at this patient and do it then and there. So CURB 65 refers to confusion, a certain level of urea, respiratory rate, blood pressure, and age more than 65. So these are the various things. And then you have here the actual numbers. And each of these points is given a score of 1. So then you add it up. Once you've added it up, how do you do a risk stratification? Low risk is 0 and 1. So you can do outpatient treatment. If it is 2, then you may have to consider, okay, may need a short inpatient stay kind of thing. And then 3 and above, 3, 4, 5 definitely needs admission, perhaps even intensive admission, intensive care. So these are the 2 scores commonly used, and which one is recommended? Now, what the ATS and IDSA guidelines say is that PSI gets a bit more weightage. It shows a bit more. So they have done extensive meta-analyses on these, and PSI is more robust, more safe, and it increases the proportion of patients who can be treated in the OPD. It also guides the initial site of treatment of patients without increasing the mortality or any other outcome. And so evidence supports the effectiveness, safety of using this PSI to guide the initial site. CURB 65, although a good clinical tool, is a little less than PSI. One thing to point out, though, is that PSI and CURB 65 were not designed to help select the level of care needed by a patient hospitalized for CAP. Although we do use it, that if it is a high score, yes, the patient will probably require intensive care, but this is not why it was devised. There are separate scores which are done for that. So this is to where is the patient best treated, at home or in hospital. And once in hospital, then again, you have to reassess which is the best place for the patient, in a ward or in ICU. So these are the 2 scores. Now coming to who to admit to ICU, which becomes very relevant for yourselves who are treating the intensive care patients. Now, 2007, the IDSA ATS criteria for defining severe community acquired pneumonia, this is what is even currently applicable in the 2019 update that we have. So it divides it to major criteria, minor criteria. There are 9 minor criteria and there are 2 major criteria. Major criteria is very straightforward: septic shock requiring vasopressors. Of course, that is for ICU. Respiratory failure requiring ventilation. Of course, that's for ICU. So these are very kind of, very black and white scenarios. No need to think too much about that. Minor criteria, there are numerous: respiratory rate, oxygen requirement of the patient, multilobar infiltrates, confusion, disorientation, a certain level of urea, leukopenia, thrombocytopenia, hypothermia, hypotension. All of these are kind of clinical parameters which definitely will ring the alarm bells for us. So it says, what is severe community-acquired pneumonia? Either one major criteria or three or more minor criteria. So you can take it from that. So this is how one looks at the IDSA ATS. Now, for these counts thing, leukopenia, it should be because of the sepsis, not chemotherapy induced. There's a second score called SMART COP. This is an alternative validated prediction rule for identifying patients with pneumonia, again, who may require ICU, which is vasopressor support or mechanical ventilation. How does this work? SMART COP is an abbreviation. So systolic BP, multilobar, X-ray involvement, albumin, respiratory rate, tachycardia, confusion, oxygen levels. Again, they're calculating the actual requirement, and arterial pH. And then this is again you score it as per these 1 or 2 points, and then you make a total. And then this is how we decide low risk, moderate, or high or very high risk. And then this is how it is used. So which to use, which fares better? Now, again, these have been extensively studied and subjected to meta-analysis. SMART COP has 8 criteria, and IDSA ATS has 9 minor criteria, and 5 have an overlap. So this means that they are roughly looking at the same thing, and we derive the same information from them. So when they do the pooled sensitivity and specificity, so ATS IDSA, it's 84% sensitivity and 78% specificity. If you use only the minor criteria, then the sensitivity comes down significantly. And in SMART COP, sensitivity 79 and specificity 64. So again, we are leaning towards this. This is a good way to judge whether a patient will need ICU care. So I think these are important to be aware of, because this is exactly the decision making that may be life-saving for the patient. Timely intervention, and we take the patient to the right place. We are not thinking, can we do in the ward and things like that. So immediately take to ICU. Now coming to chest X-ray. Now this is something you're all very familiar with, and but it always helps to discuss the simple things, because to me a chest X-ray is a very vital thing for a pulmonologist, for intensivist, because this gives us so much information. Now, if you look at it, dense patchy white opacity. So that's what we see on a chest X-ray. Could be unilateral or bilateral. Bilateral is obviously much worse. Alveolar opacity. Now, these fluffy opacities, they are alveolar opacities. And what do they indicate? That the air in the alveolar has been replaced by exudate. Now, in pneumonia, it is exudate, but bear in mind the differentials. There could be blood, which is pulmonary hemorrhage, that there could be fluid, which is pulmonary edema, etc. But, when there is bilateral. But in the correct clinical scenario, obviously, it is a consolidation pneumonia. And this is just to highlight air bronchogram. Again, the patent bronchus, which is surrounded by a consolidated lung. And this is almost sine qua non for consolidation or pneumonia. And this is the kind of patients that you all will see in ICU very often, with bilateral pneumonia, with the endotracheal tube, with monitoring wires and things like that. So this is, we know straight away, this is a much sicker patient who requires mechanical ventilation. Coming to other tests. Now, I will discuss a little more about X-rays that is going forward, but what are the other diagnostic tests in severe community-acquired pneumonia? Now, these are tests which will not necessarily be done in the inpatient, in the ward setting, definitely not in the outpatient setting, but in ICU, all of these become very relevant. So the first thing is blood cultures. In a patient in ICU with bilateral or unilateral pneumonia, sick enough to be in ICU, possibly on ventilator, inotropes, etc. Definitely blood cultures will be done because these are sick patients, and we need to, whatever identifies bacteria will always guide our antibiotic therapy. Sputum, gram stain and culture, if it is possible, then it is very useful again. Respiratory viral panel. Now, this is something that increasingly we are all doing, especially in maybe intubated patients, or even we certainly won't do it in outpatient or nor on sputum samples, best done on respiratory secretions that come from within. So either ET tube secretions or a bowel sample. And respiratory viral panel, I think, is an excellent way for us to identify a whole gamut of organisms, viral, atypical, typical, etc. What about these antigens, urinary antigen for Streptococcus pneumoniae? It can be done in ICU setting. Legionella can be done in ICU setting in sick patients, as well as where there is a possible history of exposure, of travel, of staying in hotels, and of others falling sick as well, etc. Bronchoscopy, again, this is reserved for sick patients where we can't identify the bacteria, patient is not getting better, etc. Blood parameters. Now, obviously, I'm not going to go into the details of the, the routine hemogram and kidney function, liver function. All that is going to be done regardless. You will monitor in an ICU setting, you will monitor in a day-to-day basis. These are looking at blood parameters. Will this help you make any decision in the pneumonia? So procalcitonin, all of us use it very commonly in the sepsis, in the setting of sepsis infection, to know how much it is and things like that. In the guidelines, they have recommended procalcitonin to maybe consider to differentiate between viral and bacterial. So CRP, for example, used to be a parameter that we used to use a lot, and we still do. It gives us a broad, it's a non-specific inflammatory marker, no doubt, but again, it tells us the burden of infection. So procalcitonin, in a similar way, what they have said is that less than 0.1 mg per liter may indicate viral, and if it is higher, then it may indicate bacterial. However, the sensitivity to detect bacterial infection ranges from as low as 38% to 91%. So again, simply based on the procalcitonin, you can't decide is it viral or bacterial, and therefore not give the correct treatment of antibiotics. So I think that is the only takeaway from this. So we can do it for monitoring purposes, for our, for corroborate. It kind of corroborates our initial diagnosis, but it cannot be the test for the judgment. That I think we will have to use other things. Now coming to the bacteria. Now this is very crucial, as we all know. Community-acquired pneumonia is very different to hospital-acquired pneumonia bacteria, VAP bacteria. However, there is overlap because we get a patient with community-acquired pneumonia who is sick, and as they are recovering, they may also get superadded hospital-acquired, ventilator-acquired. So ultimately, all of us have experienced these kind of sick patients who have multiple, bacteria. But the relevance of the community-acquired infection is in that first 5 days of treatment. So it's divided into the causative bacteria or organisms. So the first is the typical bacteria. The most common is Streptococcus pneumoniae, and we know this. Haemophilus influenzae is a second, Moraxella catarrhalis, then Staph aureus, then other group A streptococci. Some gram-negative bacteria, Enterobacteriaceae like Klebsiella or E. coli, but this is, again, as we are aware, that is more so in a hospital setting. If they do get it in the community, which is much lower down as the causative agent, it'll be a sensitive bacteria rather than the drug-resistant bacteria that we see in the hospital setting. And then sometimes anaerobes and things which is associated with aspiration. So I'll go over a couple of the bacteria, not too much. This is something you can get in any textbook, but a few pointers. Streptococcus pneumoniae being the commonest, I think it's important we know about it. It's a gram-positive, as we know, it's capsulated, and it's a diplococcus, and it comes in chains. This is just a simple, depiction of that. It colonizes our nasopharynx. 5 to 10% of healthy adults will have it in the nasopharynx, and it's fine till you become immunocompromised or sick in any other way, and then it can go on to cause infection. The capsule is the key thing about it, of virulence, and antibodies against this capsule is what will enable killing of the bacteria. Risk of infection is highest in elderly, immunocompromised, asplenia, remember that, hyposplenia. These are key things. They all need pneumococcal vaccine for this reason, because they are much more prone to streptococcus, to pneumococcal infection. It is usually penicillin sensitive, although, of course, in our current age of drug resistance, we will find that many will be resistant as well, but there are other antibiotics that can deal with it. Streptococcus pneumoniae, despite being the earliest, the commonest, and now, of course, perhaps it is, things are better, and the incidence in the West is lesser because of the vaccination. But it can, even a healthy young person, if they get streptococcus pneumonia, can develop life-threatening illness. So we have to respect these bacteria and how virulent they can be. Staph aureus, again, it's a common one that we deal with all the time. Normal commensal of skin and nasopharynx. It is also a gram-positive diplococcus, but it's like grape-like. It's in clusters. It's not in chains. It's coagulase positive Staph aureus, which differentiates it from the negative. They all produce beta-lactamase, and so they are resistant to penicillin. So penicillins will not work. A few like methicillin, oxacillin, flucloxacillin, these may work against it, but not the standard penicillins that we use to treat streptococcal pneumonia. What is the threat we have? It's MRSA. What we are all familiar with. It is called methicillin-resistant Staph aureus. And as we know, this is again one of the hospital-acquired bacteria that we deal with a lot of the time. And this is sensitive to a different group of antibiotics like vancomycin, linezolid, teicoplanin, etc. Staph aureus may follow influenza illness and can be very severe. It's one of the things that we, it's one of those bacteria that can cause very intense illness. Community-acquired MRSA pneumonia remains low, but you see it once in a while. And then Panton-valent leukocidin PVL toxin-producing MRSA results in the cutaneous lesions and severe necrotizing pneumonia, which sometimes you see it is from the pneumonia, but very severe. Now, maybe it is not so much relevant in clinical practice, but these are some of the things to be aware of. Now, I'll just show one case. Again, not a detailed case, but just very briefly. So this is, again, patient in ICU, bilateral pneumonia. So in the right side and the left side, so multi-lobar, multifocal consolidation. So this is a middle-aged woman. And when she came, we did a bronchial lavage because she wasn't getting better. And as you can see, we grew Staph aureus. And then this is the antibiotic sensitivity. Resistant to benzyl penicillin. So this is typical of Staph aureus. It will be resistant to penicillin groups. Sensitive to oxacillin. So this is, anyway, I won't go into detail in this because this is very much veering towards a microbiological thing. So you can have MRSA from the community. You can have oxacillin sensitive MRSA, etc. But in any case, it is resistant to a few of these, sensitive to all the MRSA antibiotics. Received appropriate treatment and then developed what we typically see, the gram-negative bacteria. And this is what I think we all dread in the ICU setting. An MDR bacteria, gram-negative bacteria, Klebsiella pneumoniae, Pseudomonas, Acinetobacter. We are familiar with all of them, and these are, very much what we see. And this is the reason why I think it is so important for us to be very judicious with the antibiotics we are using, because we have already lost the carbapenem group. And now we have, therefore now some newer antibiotics, tigecycline and ceftriaxone, EDTA, sulbactam. Unfortunately, we don't have the MIC here. So there are something, and we have polymyxin, colistin. But again, it's, rapidly developing drug resistance. So this is what we have to really be careful against. This, of course, as I say, is the overlap between community-acquired pneumonia going then into developing into hospital-acquired. So community-acquired pneumonia, the bacteria causing it is relevant for the first 5 to 7 days. After that, the antibiotics are to be attuned to what follows. The consequences of the pneumonia, like the sepsis, the organ failure, the ARD, that is a different matter. But the bacteria per se, the antibiotics relevant to that bacteria is only so for the first initial 5 days. This is more of community-acquired pneumonia, so Streptococcus pneumoniae. You can see that it is sensitive to penicillin, cephalosporins. These are the standard antibiotics, the beta-lactam antibiotics, as we call it, and then sensitive to all of these here as well, resistant to fluoroquinolones and a few others. So this would be much more consistent with a standard community-acquired pneumonia. Second is Haemophilus influenza. Again, sensitive to the standard penicillin, amoxicillin, etc., augmentin that we would use, to the cephalosporins. Now, Haemophilus becomes relevant because this is the commonest bacteria affecting patients of COPD and lung disease, COPD being the most prevalent lung disease, chronic lung disease that we see, and Haemophilus influenza is the commonest bacteria in the COPD setting. So these are, again, easy to deal with the usage of the correct antibiotic. And we must follow the tiered approach. We can't just jump and give the highest end antibiotic, which is why we are in this situation at the moment, because even small nursing homes will all give, meropenem and colistin straight away, and we mustn't do that. We must follow the stepwise approach, and the minute we identify a bacteria, narrow the antibiotic treatment right down, from starting with broad spectrum, narrow it down to the bacteria that you've. Now, this is coming to the, again, the panel that all of us are familiar with. It is a multiplex, it's a reverse transcriptase PCR. So it's an amplification process that will amplify the genetic material, the antigenic material from the virus or the bacteria. And this gives us a better idea. For example, here, so cultures will not always grow everything, and 50% of CAP organism is identified. So we have to use whatever we have in order to do this, because even viruses nowadays have become so relevant. So we do need to use whatever we have. Now coming to atypical bacteria. Now, why are they called atypical bacteria? There are several causes for this. Atypical is, so I'll read out from here, the resistance of these organisms to beta-lactams. They cannot be seen on microscopy, nor can they be cultured. So these are the ideal organisms to be identified by the PCR, by serology or by PCR. They are sensitive to antibiotics other than beta-lactams like macrolides, tetracyclines, fluoroquinolones, and they're concentrated intracellularly where they replicate. From a clinical perspective, atypical refers to something else. From a clinical perspective, these patients may often present with other system symptoms. So they may not have respiratory symptoms as much as having GI symptoms, or sometimes they'll have ear symptoms, sometimes neurological. So they'll have other system involvement. So atypical bacteria, this is the important thing about them. What are they? So first is Legionella, then Mycoplasma. These are the ones which are very relevant to us. Then Chlamydia, Pneumoniae, Psittaci, and Coxiella burnetii. Not as common, and you may identify it on the panel, the respiratory panel. So Legionella, now this is an important one for us. It may not be common, but it does cause very severe illness. And again, once identified, can be quickly treated with macrolides and fluoroquinolones. It's an aerobic gram-negative bacillus. It's motile, non-acid fast, produces beta-lactamase, so resistant to penicillin. Present in water, natural habitats, as well as in artificial sources like air conditioning, as we know of, fountains and respiratory therapy equipment, etc. So young patient smokers, severe infection may be there in elderly and immunocompromised. Multi-system involvement is not uncommon, with mental status alteration, liver enzymes, diarrhea, along with the pneumonia. Travel may be present, not always. And it's sensitive to macrolides, fluoroquinolones, and rifampicin. So the history, the classical history for this is someone who has traveled, who's traveled, gone somewhere, stayed in a hotel for a few days, and the air conditioning was infected, and numerous people have fallen sick with it. So this is like a very classical history, not always so easy to determine, but Legionella is important, and it can be identified by the urinary antigen and can be aggressively treated and does respond. What about Mycoplasma? Mycoplasma is again a different one, where we have a lot of extra pulmonary manifestation. There can be neurological manifestation like meningitis of different types, neuropathies. There can be hematological, there can be skin and mucocutaneous, musculoskeletal. This table is not complete, but just to give a sense that this is, Mycoplasma is the one where you have to look out for other system involvement. So they can have skin lesions, classical skin lesions and things like that. Now, typical clinical features include a pharyngitis, sore throat, hoarseness, fever, cough, etc. And this indicates infection in the lower respiratory illness. Extrapulmonary manifestations overshadow pulmonary, and this is classical for atypical bacteria. 25% of the patients infected with Mycoplasma pneumonia may experience extrapulmonary. So that is the typical and atypical bacteria. Now coming to respiratory viruses. Now this is of course very key for us, and we've all just about, we are still in the, we are not over the pandemic, but we have recovered from the intense onslaught of the pandemic at least. So there are two things, mainly influenza and SARS-CoV-2. Now influenza, I'll just point out a few things. Again, I'm not particularly looking at the intensive care perspective of it, but I'll give some wider kind of insights into it. Influenza, who does it affect? Again, that same category, the extremes of age, very young, very old. pregnant and postpartum 2 weeks of delivery, chronic medical conditions, and immunocompromised. Early treatment with antivirals do reduce symptoms, complications, hospitalization, mortality. So it's important to identify quickly and treat, even empirically sometimes, and then wait for the report to come back. Vaccination, we're all aware of. Influenza vaccine pre-winter has to be given to everyone, in the very young, in the elderly, and anyone above 60, anyone above 50 with chronic illnesses. And now, in fact, it is recommended for everyone since COVID has happened, and everyone's fearful of the dual kind of epidemic in winters. Fortunately, it has not happened, but it is a reasonable thing to do. Healthcare workers as well, all of us are, it's important for us to take it. And annual vaccination is the best thing. Chemoprophylaxis with antiviral is also used for pre-exposure or post-exposure prevention. Now, one thing to remember is that viral illnesses are highly infectious. Bacterial infections may not be. Bacterial infections may be infectious in people whose immunity is compromised, but in immunocompetent adults, they will not necessarily, one will not transmit one bacterial infection from one to the other. On the other hand, viral illnesses will transmit to everyone in close contact. So that's something to keep in mind. Influenza and bacterial co-infection. So this is an important thing to, again, very relevant to us, because during the flu season, I think all our ICUs get inundated with influenza with bacterial infection. And that is something for us to be well aware of. There are two things to look into this. One is that, yes, there is co-infection. If there is influenza, there is the immunity is also compromised, and the patients can get superadded bacterial infection. So treat the bacterial co-infection empirically. It's okay to do. Then, so people who have suspected influenza and severe disease, and those who deteriorate after initial improvement. So again, if there is secondary infection, so there might be an initial improvement followed by decline. So just have a low threshold, and these are very valid places to treat such patients. So you have a patient in this situation, then. So again, the same thing it's pointing out. What about diagnosis of influenza? Again, as we pointed out, rapid molecular tests, like this nucleic acid amplification. We have that for almost. CBNAT is now available for all viruses, SARS-CoV-2, influenza, RSV, etc. And then we can do RT-PCR and the part of the respiratory panel. Now, one thing to point out that I haven't really done in a slide form is that influenza is endemic. I think we all understand these things quite well now. Influenza is endemic, and when any infection becomes endemic, what does it mean? That it is there, in the population. So it exists, it continues to thrive in the population without causing any significant illness. But from time to time, so we all know that during wintertime, influenza will, peak. We all know that, and everybody takes a vaccine, but people still tend to come down with it. Within this peak of influenza in the winter, there will be some severe cases of H1N1. So this is the way the severe illnesses work, and perhaps that is the way the SARS-CoV-2 will as well work. So while we have Omicron in our midst, or variants and subvariants, etc., of that, but from time to time, we cannot say that we are, completely do away with it, because from time to time, when there is a peak of the infection, while the majority, 90% will have, 90 to 95% will have very mild upper respiratory tract illness, there will be some who will get the, more severe variant. So these variants perhaps are just in abeyance, they don't entirely go away. So that is just something to point out, although I haven't really brought it up here. And from the ICU setting, so I'll just, again, even the COVID, now I haven't really prepared many slides for it, because these viruses, they come and go, whereas the bacterial infection are what we see all the year around, and they're the ones which last much more. But there are excellent guidelines, and I think we just go over it, and the current, all of us know of the evidence or the lack of. And I've just shared just one slide I'll share of the typical CTs that we saw at that time. And we saw this kind of, there's extensive consolidation, ground glassing, there's a bit of crazy paving. And then here there is some traction as well, traction bronchiectasis, indicating, septal parenchymal stiffening. And then, of course, the good thing was that, again, here also, this is crazy paving, where on top of ground glass, you also have septal. Good thing was that recovery was there. So after some time, they became like this, where all the acute ground glassing and consolidation resolved. And then what we were left with was the septal thickening, and that got further better. And just some subpleural, like a pleural stripe was left behind. So based on this, all I'd like to share is that viral illnesses often cause bilateral disease. They often cause interstitial pneumonitis rather than the classical lobar consolidation that a bacterial infection causes. Bacterial is much more unilobar, and if it is multilobar, multifocal, it just means it's much more severe. But in a viral illness, it is much more common to have a bilateral, multifocal kind of disease, which may look like this, and definitely during COVID it looked like that, and H1N1 will also look like this. And again, the things to bear in mind: prompt start of antiviral, empiric antibiotic, don't hesitate, and the support, the ventilatory support or whatever other support is, of course, what is special cases. So this is again more in the remit of hospital acquired, but I'll just mention a couple of things that sometimes we do see the MRSA even community acquired, and strongest risk factor for this is previous colonization. So patient may have been in hospital, got discharged, and come back a month or so later, and maybe in the first, and may have come back in the second time with a community acquired infection. But then what we find is that it is MRSA, and it may be because it was colonized all this time. So that is one of the reasons. And this empirically, we need to treat them if we have this history. We don't need to wait for such patients. And then the other thing, I've just faded it out a little bit, is because suspicion for MRSA is again that whole cohort of vulnerable people, previous IV antibiotic, hospitalization, kidney disease, and then certain IVDU, then socioeconomic things, lifestyle, etc. Staph can cause a very significant necrotizing cavitary pneumonia. The other thing is Pseudomonas, but of course, all the guidelines will say Pseudomonas because they see this more commonly in the West, but we will refer to it as the gram-negative bacilli. And again, drug-resistant gram-negative bacilli is something we encounter. And known colonization, past infection, hospitalization with IV antibiotics in the last 3 months. And then, we need to give them an empiric regimen. Pseudomonas is identified as a cause of CAP in 4.2%. So that's not, we can't ignore that. And the isolates were drug resistant in approximately half of the cases. Independent risk factors: prior Pseudomonas infection or colonization, bronchiectasis, severe COPD, tracheostomy. So as a pulmonologist, we encounter Pseudomonas a lot, and in bronchiectasis and as COPD. And the thing to know about Pseudomonas is that colonization, so it's not good news. And whenever we isolate it, we have to try and eradicate it, because once it's there, it takes root and it'll cause recurrent infection and ongoing lung destruction. So Pseudomonas is a very dangerous bacteria. And whenever we treat it, we need to use double antibiotics, one intravenous and one more, which could also be intravenous or oral if it is sensitive to fluoroquinolones. Very often we find that it is resistant to the oral fluoroquinolones, and then we have to give either 4th generation cephalosporins or the penams along with the amikacin with the aminoglycoside group. So Pseudomonas, of course, is a very special case with a separate kind of connotation from the respiratory perspective, but gram-negative bacteria that we see in the ICU setting will include Klebsiella, Acinetobacter, Pseudomonas, E. coli, etc. And these are again the drug resistant, like we saw that culture report. Coming to treatment. Now, treatment is for straightforward community acquired pneumonia is fairly simple. So I've not kind of gone into too much of that. So initial treatment strategies for outpatient, this is very simple: amoxicillin or doxycycline or macrolide. If there's comorbidity, then give double. So I think I would give, for a community-acquired pneumonia, regardless, I would give a double antibiotic. One is simple amoxicillin clavulinate, and one is a macrolide. And that would be the standard of practice for everyone. And then we come to community acquired pneumonia, more severe, which we've had to admit. Then typically, if we have amoxicillin and clavulanate, that remains IV remains an option, but typically we would start a beta-lactam. Well, we would start either a cephalosporin, either IV monoceph or something, along with macrolide or respiratory fluoroquinolone. Respiratory fluoroquinolone, as you're aware, in India we are very hesitant because of the implications of TB, because we sometimes don't know someone presents as pneumonia but may have underlying TB, and then we render them fluoroquinolone resistant. So that has to be borne in mind. So non-severe inpatient and then severe inpatient, we have to bear in mind MRSA coverage, gram-negative coverage, and especially if these recent hospitalization and things are there, then empirically as well we can do that. We can cover for this. So so this is the thing about antibiotics. So just what is the duration of treatment? 5 days of antibiotics is usually enough from uncomplicated community acquired pneumonia. So the patient I'd see in OPD, I will just treat for 5 days, that's enough. But however, if a patient is immunocompromised, has underlying structural lung disease, is not better than 7 days. In the ICU setting, often you'll have to give 7 days, 10 days, 14 days even. If blood culture grows something, then straight away it's into 14 days. So I think it's very much based on where things go. Non-traditional CAP like Legionella, Pseudomonas, Staph aureus, then longer duration, as we know, especially if there is bacteremia. Drug resistance, I don't know if there's time to go into this, but anyway, the mechanisms of drug resistance, something we have to be familiar with, so that that is part and parcel of our attempts for judicious use of antibiotics. Important trends, as I said, this is of course in the West, decline in strep pneumonia is, it used to be the most frequent, but now it's decreasing because of vaccination and herd immunity in the population. 30% of cases in Europe and 10 to 15% in the US. So higher uptake of vaccine in the US. I don't have data for India. COVID, we have, I have not gone into it because that is again, and I think that's for one entire lecture really. Increased recognition of respiratory viruses. 1/3 of cases of CAP end up being respiratory viruses when we use the molecular methods. So I think those are excellent and we must use them. Single pathogens, sometimes they're co-infections with bacterial CAP, and sometimes they just cause dysregulated host immune response. That makes us more prone to bacterial infection. Lung microbiome, just like the gut has a microbiome, the lung also has one. So they are already there. And sometimes the response, which bacteria causes the pneumonia is often a factor of what the lung microbiome has. So, it may overshadow that, or it may be the one, etc. Some newer antibiotics, but not at all used here. So I've not gone into detail but it is FDA approved. So in the future, we may have that, which is a good thing. I think we can do with newer antibiotics whilst trying to save what we already have. And I think with that, I come to a end of this session, and I really hope that that was useful. Dr. Gunadhar, over to you.
Thank you, Dr. Bernali. It was indeed very elaborative and very interesting discussion. Yeah, Dr. Gunadhar.
Yeah, thank you. And I think it's an extensive talk. Everything has been covered very nicely. And I think whatever the guidelines and literature is available in the current scenario, I think you have beautifully described it, which will be helpful for our students. So from the intensivist perspective, only I would like to mention a few points which is important for the students actually. So one is like, as you have pointed out, like how to know that it is a severe pneumonia. So like patients who are sick, who are requiring mechanical ventilators, who are requiring inotropic supports, they are classified as a very severe category of community acquired pneumonia patients. So these patients should be immediately admitted to the ICU. And as an intensivist, they should not forget about the role of resuscitation in the ER, sending the culture before giving the antibiotics, and suspecting the appropriate work for that particular patient who comes from the community. And here the antibiogram of that particular community also matters. Like many of our patients who come to our hospitals, basically, if they are in shock, we start with BL-BLI combination, followed by atypical coverage. But in some hospitals, that may not be the scenario. And the second thing is like scoring system. Ideally, as you have beautifully described, like the curve 65, pneumonia severity index, the smart cough. So, so most of them being should be categorized in either of the one form. But what is more important is the organ involvement. So any patient with community acquired pneumonia having organ involvement, obviously the severity increases. Like if there is a one organ involvement, either kidney or liver, the severity is more. If there is two organ involvement, the mortality is high. The risk is high, the prognosis is poor. Third thing is like the patient should be treated like in the proper ventilator strategy, like ARDS ventilation, if at all, because most of them are sick and they are requiring very high PEEP and FiO2. So sometimes, though, sometimes the proning also helps them. Many of our patients, actually, we have proned them when they came to the ICU with a severe community acquired pneumonia, and that sometimes helps them. So the lung protective ventilation strategy sometimes helps in such patients. And the other things like very rarely we encounter fungus, because most of the times, though even if you isolate fungus from the respiratory tract, the fungus can never be a cause of the most of the times pneumonia, like candida can never be most of the times a cause. Though in a chronic patients, aspergillosis sometimes may be common, but most of the times empirical antifungal actually has no role. But if the patient subsequently deteriorates, we may have to add either amphotericin B or sometimes like caspofungin, okay, as empirical treatment if the patient is septic shock, not recovering. And diagnostic modality, like as you have rightly pointed out, that the BAL and mini BAL and the brush specimens, they are of diagnostic value. And the intensivist of our students should be able to know about the something called as the your something that scoring system of the microscopic scoring systems. Okay, so those are also important. And prognostication wise, we should be able to explain to the family, depending on the organ involvement, what is the chances of mortality of different category of patients who are on ventilator, who are requiring inotropic support, and who are having multiple organ involvement. So in that way, we have to classify to our relatives of the patient relative, I mean to say, so that those will be the documented communication part from our sides. And I really thanks. You have covered everything extensively. So any questions is there? I think we can take. Akhilesh, if you have any questions.
Yeah, yeah. Thank you. No, it was indeed a wonderful, presentation from your side, and you gave a lot of insight. What we have seen in our setups as well, like there is growing incidence of multi-drug resistant organisms. Even with community acquired pneumonia, we've seen a lot of patients with multi-drug resistant organisms. What is the trend that you have also followed up? And we have a lot of discussion about what is the suitable antibiotic even for community acquired pneumonia. Sometimes we use the tazobactam, sometimes we use the sulbactam, sometimes we use other combinations like so many sulbactams and BTs have also been added. Considering that community acquired infections are also multi-drug resistant organism induced. So, what is your take on this particular entity? Do you also find multi-drug resistant organisms even in community acquired infections like pneumonia?
Yeah.
I'd like to hear from you.
Yeah, so certainly I think from the intensivist perspective, you will see much more drug resistant bugs in the ICU setting. Now, for us, it is patients who will be on the ward and all that, perhaps not so much. We our first antibiotic of choice for an admitted patient will be a combination of monoseph and macrolide, clarithromycin, typically. And mostly patient will respond, but yes, you're right. Often we go straight to piptaz and Claribid if we feel that the patient is has comorbidities, because it's so many of our patients already have COPD, already have cardiac disease or something or the other, and then we feel it is wiser to this thing. But monoseph and clarithromycin otherwise I think is a good choice. Augmentin Claribid is good for the patients who are being treated on an outpatient basis, so that's not relevant to you, I know. So my kind of
So most of
perspective
our
comes much
patients
more from that.
so most of our patients are exposed to healthcare setups. They may be visiting
Exactly,
the hospital or OPD.
Yeah,
And
yeah,
that's why
absolutely.
they become colonizers.
Absolutely right.
Most common organisms would be Pseudomonas probably, and
Yes.
with the structural lung diseases, we tend to get recurrence of infections, and colonizers are also not treated, adequately at times. Probably the duration
Absolutely.
of antibiotics is also not adequate.
Absolutely.
We emphasize on shorter duration of antibiotics, like 5 days or maximum 7 days or something like that. But we've seen even community-acquired infections are also multi-drug resistant. So at times we have to give long-term,
I
at least
agree.
2 weeks of antibiotics, are also
I agree. Mm.
especially for those patients with COPD. Like now COPD, though, I don't know whether we should call them as community acquired, because they will keep on visiting the hospital, so they will invariably have health nosocomial infections only. So, means as far as the penetration of these antibiotics is concerned, when we compare BL, BLI, so which one do you feel has a better penetration? When we compare, like from intensivist perspective, like piperacillin tazobactam versus cefuroxime sulbactam,
Mm.
what do you think will be better?
So I still feel, I mean, so while we have, cephalosporins, we have so many options. Options are, ever increasing. Piperacillin tazobactam, I feel, still has a very good place, and we would still preferentially use this. But of course, cefparazone sulbactam is again, commonly used for more slightly more broad spectrum, I guess. But from the respiratory point of view, I think piperacillin tazobactam would still be a preferred drug for us, along with atypical cover from the CAP setting, from the community acquired setting. So yeah, so I think that would be.
Yeah, there is one more question, like in the chat box. How do we differentiate between aspiration pneumonia
Yeah, I'm
and
sorry, I didn't. Yeah,
pneumonitis?
yeah, I didn't address that
Is
at
it?
all. But yes, I agree that aspiration is something we see very commonly. But I think the thing to understand about aspiration is the background of the patient. So a patient who has underlying, either a recent stroke or has some, neuromuscular problem, or may even have some head and neck surgery, anything that affects the integrity of the swallowing, and so during swallowing the throat muscles have to work, and the vocal cords have to close completely. So anything that interferes with that mechanism. So more than anything else, I think we know it is aspiration if the patient has these as background, and if the family says that during eating or drinking he starts coughing a lot. So I think these are key indicators. Typical chest X-ray changes would be in the right lower lobe, because aspirated material will always preferentially go there, and then you can confirm it further with a swallow assessment and things like that. There is guidelines about whether is it important, because we all add anaerobic cover as well in these patients, additional anaerobic cover, and is it necessary, or whether something like piperacillin tazobactam can also work just as well. And I think the guidelines say there is no need to add additional antibiotic for aspiration, because these cover it just as well. They cover it adequately. But I think, again, some degree of clinical judgment. But this is how I think the aspiration and regular pneumonia and aspiration pneumonia is purely history, on the basis of history.
Yeah, you talked about Legionella infection, which is common with the NAC environments and all that. So, is there any recommendation? Like, we have always read in the textbooks only, particularly for Legionella infection, we should simultaneously send the urinary Legionella antigen. What is the recent recommendation of that? Do you still follow the
Yeah.
protocol of sending urinary antigen for Legionella, or just respiratory specimen?
No, so I think the
Sending
guidelines say
respiratory
they
specimen.
say that in the case of severe community acquired pneumonia, must send the urinary antigen as well. Either severe community acquired pneumonia or a history suggestive of exposure like that, they do kind of this thing. They do recommend to send the urinary antigen as well. But a person who's on the ward and otherwise getting better, then then that's okay.
Yeah. So another thing is like steroids. So most of the times, the steroids actually have no role. If you say most of the times the viral pneumonia, people tend to use steroid, but actually sometimes it is detrimental. In fact, it has to be used only if there is evidence of inflammation, like most of the times in COVID we have used. But sometimes in the initial phase after 5 days of the symptoms of community acquired pneumonia, when it is not settling down, many of the intensivists they tend to use steroid. So, what is your experience on that? When do you really use steroid in such patients?
Yeah, so no, I agree. I think in the setting of only pure pneumonia, I think steroids have no role at all. The role comes, suppose, we see a lot of COPD asthma patients and things like that with pneumonia, who will come with a not only a consolidation, but also an exacerbation of the airway disease. And then that's one of the indications, certainly. Second is, again, septicemia and all that, sepsis dose, a low dose steroid may be, considered. But for the pneumonia per se, I wouldn't. Now, again, viral pneumonia is different. When we dealt with COVID, in the early part, steroids are not to be given because it encourages, it is conducive for the viral replication if we give steroids in the beginning. After a certain stage, however, when the bodies, when we dealt with things like the cytokine storm and all that, probably at that time, I think we had good evidence from the recovery trial that steroids were certainly helped at that point. So yes, definitely a very judicious use of steroid. And for pneumonia per se, I don't think so.
Yeah, absolutely.
As far as the
another question
is concerned,
another question is like, so one question is like H1N1 also able to cause pneumonia, and how does it if it is so? And how good is the sputum positive report of identification of organism? How reliable, how sensitive and specific it is in your clinical practice, madam?
So H1N1 can cause pneumonia, definitely. So with the viruses, it's that, as we discussed in the presentation, they can cause pneumonia. It is different to bacterial. Bacterial is much more lobar consolidation, and viral is an interstitial pneumonia pattern. So it'll be bilateral, it'll be multifocal, and it'll not look like a standard pneumonia. But if you do the CT scan and all that, then it'll be much more obvious it's an interstitial pattern. So H1N1 by itself can cause pneumonia. It can cause immune dysregulation and predispose to superadded bacterial infection. And so both are possible. But yes, even by itself, viruses can cause pneumonia. Sputum positivity. Now, see, I don't know the specificity, sensitivity, but what the data says is that we are able to identify community acquired pneumonia only in 50% of the cases. So obviously, sputum is giving us that much information. This is in the context of CAP, so maybe just half the people we will get the diagnosis. Now, if the patient is producing adequate sputum, we must test it, because if we get an answer, it will only help us, rather than giving multiple antibiotics and things like that. And we have identified a bacteria, we narrow down our treatment to that. So I think sputum must always be done, but it will give you the report. It will give you an answer maybe only in 50% of the cases.
So the sputum should be sent unless good, otherwise all patients with the respiratory symptoms.
Yes.
But the volume of the sputum is also very important.
Very important. Absolutely. So if there's adequate, and like Dr. Gunadhar said, preferably send it, before antibiotic treatment, because a lot of the time there are so many antibiotics, and no culture will ever grow anything. So I think best to send off a sample as soon as possible and then let the antibiotics start.
As far as the guidelines are concerned, there are many guidelines, BTS guidelines, American Society guidelines. Now, Indian Society of Pulmonology also have come up with a guideline. So, which guidelines should we follow for a trainee intensivist? If I talk about, and we are like in intensive care, we have the trainee students. It becomes very confusing. Well, like when we were training 15 years back, probably we also had confusion which guidelines to be followed. So what is your take on this particular? I have these questions in years together, and still I'm not able to delineate. So which guidelines we need to follow?
So I think that's I totally understand. I think that's a very good question. Now, I mean, by and large, so from the respiratory perspective, I think we must have one Indian guideline that we must be familiar with. From the pulmonary perspective, it's ICS and NCCP, Indian Chest Society and NCCP. So they have given us, I think it's 2018 for CAP, the guidelines are there. They're not terribly different or anything, but it's good guidelines. Sometimes it gives us a good Indian context, so there will be some things which are specific to India. From the Western guidelines, I think American Thoracic Society and IDSA, they are very good. They have guidelines on almost all aspects of infection. IDSA anyway has for all infectious things, and for respiratory specific, I think the ATS and IDSA was a very comprehensive, Q&A based. So this is the question: what is the evidence, and then what is the guidance. So it's quite a nicely done this thing. So I thought that was good. British Thoracic Society is also very good, but theirs is very outdated now, this for CAP at least. So I think it's important to go to the guidances which are in the last few years, in the last 5 years or so, because evidence is changing so rapidly that if we take something from 2010, it's probably very grossly outdated, and especially in the field of infection, because new diagnostic, new treatment, so many things are being discovered. So that would be my take, but yeah.
Yeah. So a very interesting question by Dr. Biswas. So she wanted to ask, is COPD can be totally curable?
So COPD is a chronic illness. So as you know, chronic illnesses are usually not curable, they are controllable. So by and large, I would say COPD is a chronic disease, and the smoking or whatever environmental damage causes extensive, irreversible emphysema in the lungs, emphysema or airway changes. So it cannot be reversed. It's irreversible. So it cannot be curable. However, people who have mild COPD, like the initial stage, if they give up smoking and there is no lung damage, perhaps that is the category that may be curable. But for all the rest, I think it's probably something that can be controlled with using inhalers. Yeah, so so only very early onset who have not smoked that much. But once you have emphysema in the lungs and your lung function test is showing airflow obstruction, it is not going to be reversible. So this is different to asthma, which is the other airway disease, which is totally reversible disease. But these are all chronic illnesses. So chronic illnesses are by and large not curable. So you can control them with treatment.
So as far as PCP pneumonia is concerned, it can present in different ways, like atypical PCPs are also very common. And at times it becomes very difficult to identify, and culture also. To culture it is also very, very difficult. So how do we,
sorry, I missed that. What is difficult to culture? Sorry, Dr. Anlake, I've missed that.
Yeah,
PCP.
Zero.
PCP,
yeah, initially it was the PCP.
Absolutely.
Now the name is PJP, something like that. So it becomes very difficult to identify these organisms in culture. So what is the best way to identify PCP? So simply by just imaging modalities sometimes doesn't help, because ground glassing is seen in many other conditions, even flus. Even COVID pneumonia also has a similar kind of picture where you see ground glassing. It becomes very difficult to identify PCP. I know if the patient is on steroid compromised, where we should have strong index of suspicion for PCP. But there are typical presentations. Even if the patient may not be immunocompromised, but there may be presence of PCP in these patients. How do we diagnose PCP, and what will be the best line of treatment for PCP infection? It may also present as a community acquired.
Absolutely right.
Directly coming in community infection. So, but it becomes very, very difficult to diagnose.
I agree.
What is your take on this?
So I think you're absolutely right. But I think it's the key thing to, again, I think a lot depends on the underlying conditions. So obviously PCP, we will be expecting in someone who's already immunocompromised, in some way. It can be because of underlying malignancy, chemotherapy, or it can be a hematological malignancy, which is often one of the, and of course HIV and all, depending on what the, in India, obviously it's not that prevalent. But so I think the first thing is that the patient has to be immunocompromised. Only then we start suspecting it. And then once we suspect it, I agree with you. Diagnosing is not always easy because it is only the methanomin silver stain or some like the microbiological this thing which doesn't always give us. I think a good clinical suspicion is also okay, and a combination of Septrin and steroids is good. I mean, high dose Septrin, of course, for a so I for sure we have given it empirically when we have a very strong suspicion. Although one would feel much more confident when you actually have the microbiological confirmation for it. Other thing is, of course, desaturation. I mean, people do the walk test and the patient desaturates, and in a background of immunocompromised with classical ground glassing in the center with peripheral sparing. So if everything adds up, then I think
Yeah. So I think, Madam, yeah. So you are rightly, absolutely true. So in the background of immunocompromised patient who are rapidly hypoxic, rapidly deteriorating with some component of lung injury and suspicious of pneumonia. So probably this is where the PCP pneumonia actually should be taken in the high index of suspicion. So that is the key actually. So once you suspect, then only we can send the different test. So that is where your clinical judgment and your patient management play a very vital role, what I suppose. So okay, so that's a very good discussion. With the interest of time, I think we need to close today's session. And I really thanks Madam for giving this talk to all our budding intensivists, and hope to see you soon in the future in this on our platform many times. And really thanks from all our Apollo team, Apollo Navi Mumbai team, I can say. Thank you all. Thank you all. Thank you all for joining.
thank you, Dr. Gunadhar. Thank you, Dr. Akhilesh.
Thank you, Dr.
Honor to be here. Honor to be here. Thank you.
Thank you. It was a great. Thank you.